Makofi jamani kwao, makofi.
Excellency, these tablets are meant to empower the CHAS to undertake the digital reporting, as the CHPs already have phones that they report through the EGs. So we kindly request that you present them to the representative of the CHAS. Mr. Koech. Thank you. Pigeni makofi.
Your Excellency, Deputy Governor, the CEC, members of the CHMT, members of county leadership, our partners, the chairs and the CHPs, colleagues, ladies and gentlemen, good morning. Good morning once again. I bring you greetings from the Ministry of Health, and more importantly from the Division of Mental Health, where we're very proud to see the results of something that we started a year ago in collaboration with J, Amref and other partners, culminating to today's event that is even going to strengthen our partnership even better to make sure wachani pambwe. Nilikuwa nashangaa kwa ni mimi siweke yaka kakitu watu wanae ama sijatosha mboga. Anyway, that is on a light note. So I just want to echo some comments that were made here earlier by my colleague and fellow psychiatrist, Dr. Wafula. Ametaja kitu ambayo imeniguza kuhusu hii county ya Nakuru. Kwanza kabisa, the Deputy Governor, your county is doing quite well in mental health. You have a very strong team led by the focal person and the psychiatrist. In fact, a lot, even the data people, sometimes I even refer to the data from Nairobi County because of the way it's very well analyzed and it's able to give us feedback at national level on what is happening in the counties. So we really appreciate your team. Then I did some maths. Dr. Wafula said you have 6 psychiatrists and about 120 beds, and your population is about 2.3 million. They're about muko watu 2.3 million. So the 6 psychiatrists are serving about 350,000 Nakuru residents, kila mmoja. So when Dr. Wafula was speaking here that they see 100 people per week, that's just a drop in the ocean. So, but I do appreciate that you're one of the counties with the largest number of mental health specialists. There are some counties that have 0. So wapigieni makofi, wamejaribu sana. So looking at the national level, we estimate that karibu 1 person out of 4 kwa maisha yao watakuwa na ugonjwa wa akili. 1 out of 4 Kenyans in their lifetime watapitia changamoto ya afya ya akili. Na sitaki watu waanze kuhesabu mahali wameketi, sababu hiyo ndio hufanyika nikisema hivyo. Kitu kingine tunajua ni kwamba watu wale huja hospitali kwa matibabu ya jumla. Hata sisemi wale wanaenda kuona Dr. Wafula and team. Wale wako outpatient, 25% of them present with some symptoms of mental health conditions. Na wale wako kwa ward, be it surgical ward, maternity ward, any other ward, about 40% have symptoms of mental illness, and most of them go undetected. Wanatibiwa maumivu, headache, hapa na hapale syndrome. Si mnajua vile tunasemanga madaktari eh? Upati ugonjwa ni nini? Mtu anashinda akirudi kwa clinic, but nobody can detect what it is. Out of the people who need mental health services, tumesema ni moja kati ya watu 4, sivyo? Out of those, 75% hawapati matibabu yanayofaa. So there is a big treatment gap. Yet, our constitution and our health act, our mental health act, our mental health policy, we are supposed to assure Kenyans of the highest standard of health, including mental health. And from our old mental health act that we inherited in the colonial time, we concentrated so much of treating mental health in a silo and segregating it from other health services and institutionalizing, yani kufungia wale watu ambao wako na mashida ya afya ya akili kwa mahospitali badala ya kwenda pale kwa community where they are. Something you don't know is that most of the mental health conditions can be prevented. Pole sana. Na hiyo inaweza cause mental health problems, by the way. Yani kuna vile tunaweza kuzuia magonjwa. Kwanza ni kujulisha watu kufahamu ni nini ambayo kinaweza changia kufanya afya yao ya akili isiwe sawa. Ingine ni kuambia watu vitu ambazo wanazofanya ndio wa promote afya yao ya akili. Ya tatu ni kugundua yule ako na shida ya afya ya akili mapema and connecting them to the care and support that they need. So that is why, in alignment with our Constitution, our Health Act, our Mental Health Act, we have moved away from institutionalization and silo approach in mental health care to integration of mental health in primary health care, in community, and in all workplaces, including workplaces and school, so that we can reach people where they are. And therefore, in the spirit of universal health coverage, we have worked very closely with J&J, Amref, and other partner to train not only healthcare workers in primary healthcare, but also our community health promoters and our CHAs to be able to screen, recognize, care, or refer people appropriately early enough. Ndio tusije tukafika mahali lazima mtu ekwe kwa institution. So this helps bring service closer to mwananchi and also helps ensure that people feel dignified and respected. And pia inatoa ile stigma. I know when people have to go and see Dr. Wafula, it is associated with a lot of stigma. Deputy Governor, right now, if you had tonsillitis and I told you go and see the ENT surgeon, utatembea na uambie kila mtu kwa ofisi naenda kuona ENT surgeon. But ukiambiwa naona governor uko na depression naenda uona Dr. Wafula, utasema niko na kamkutano mahali. Si ni kweli? So we are normalizing talking about mental health by integrating it in our community health approaches, in our primary health care, and in all across. And this act that we are doing today here of strengthening the CHAs to be able to supervise is also a way of being able to collect data. The investment in mental health, as Dr. Wafula has said, has been very low. Tuko na changamoto, sio Nakuru peke yake, nchi nzima na even worldwide. There is very little resources that are allocated to mental health. And I always challenge people and say the reason there is low investment is also because we don't have data. We do not have data, hatujui ni watu wangapi, sababu labda watu wanaficha, ama sisi wenyewe kama watu wa mahospitali ambao tunahudumia watu, hatuandiki, hatureport. So with the use of these gadgets that are being distributed today, they will help us collect data adequately that will be able to inform us how to invest in mental health. So this is a significant moment also for defining the policies and investment for mental health in this country, because it will support data collection. And beyond that, it will also help support linkage. But there is somebody who told us something 2 days ago where we were doing a similar exercise, that musifikiria kupewa hizi tablets, sasa kazi imeisha, tablet ndizo zitafanya kazi. Technology does not work for you. You work with technology. Mkipewa hizi tablets msisema sasa tumetosheka, kazi itaiva. You still have to be dedicated as you were before. You still have to utilize them in the correct way, so that you're able to serve mwananchi and they can also be of value and benefit to advisors in the policy. Ensure that there is proper referral for patients and nimesikia venye mtu amesema hapo, these guys know how to sneak. Asks. I heard the ask how it was passed to you, and I'm sure it landed in your ears. Tunatarajia hizi hazita faili network ya hizi ama aje, Mr. Gitau. So don't take it that getting this tablet solves all the problems for you. It is still you who has to go and attend to the patients, attend to our wananchi, and ensure they are linked properly to care and support. And final part that I want to emphasize is that we have done a lot of training for the CHP, and with the collaboration with Amref and the Division of Community Health, we created a training package specific for CHPs on mental health. It is at our MOH Virtual Academy. MOH Virtual Academy is something that is accessible on the internet, on the web. You just go online, MOH Virtual Academy, and look for the CHP training modules, and then there's a mental health module. DG, I can tell you, it is the most accessed module among the CHP's modules. I don't know why it drew so much interest. So we are very, very encouraged, because all our CHPs have actually gone to that and completed that training. But it is not just for CHP alone. Even CHAS, even the other community workers, and all of us who are interested in mental health, it is very simplified. You're able to learn how to know somebody who has a mental health conditions or is likely to have a mental health condition, and refer them to care, or even provide some basic support. And today I want to encourage all our CHPs, because I know sometimes we are replacing our community members. Please go to that site, enroll in that module, and complete it, get a certificate, so that, the skit was very nice, but there were some things we were discussing here with Anthony that can be made better in our communication language when it comes to mambo ya mental health. Sababu kuna lugha pia tunatumianga kwa mtaa hapo tukiongea mambo ya mental health, inaleta some people feel uncomfortable, and maybe I overanalyze because I'm a psychiatrist. But so please log on to that portal. I wanted to make sure that I mention here that, so that you are able to correctly identify and refer the people. And don't just go looking for people who are sick. Look also for people who are well, and they need to be told how to stay to be well. Mental health is not equals to mental illness. Mental health is a state of well-being where you're able to fulfill your potential. And all of us are born with mental health, and all of us are able to safeguard our mental health. It is a mental illness we do not want to have, but even when we have the mental illness, it can still be managed, and you're integrated, a productive member of a society. So closing this gap when it comes to mental health service is not simply a health sector issue. It is a constitutional and legal and moral obligation for us. And let us also make sure we respect those constitutional rights of the people we're living with mental illness. Asanteni sana, and I wish you the best.
To take this opportunity to invite one of our major partners, Dr. Kanari, to give her remarks. Tumkaribishe kwa kumpigia makofi. CHPs, figelegele.
Good morning, Your Excellency, CEC, all protocols observed. Habari zenyu. Iko mtu hapa ananijua? Inua mkono kama ushainiona mahali. CHPs mnaniangusha na nawajua. Mnaniangusha sana. We are very happy to be here, and Your Excellency, we want to emphasize that as Amref and on behalf of our country director, Nakuru County has been one of our key partners. So this program is a national program but began implementation in Nakuru, and we have worked hand in hand with the county. The partnership has been very sustainable and very impactful, and we began the journey by training the CHAS and the CHPs. So we are coming full circle. We are now training the healthcare workers, so that when we have these mental health cases, they're able to handle them. And so today, one of our key things is we want that digital transformation to speak, not just at the top, but huku chini. So we are here to then, we had the needs for the county. Madam CEC and her team at the CHMT guided us on what Nakuru County needs. And that is how we partner with our partners. And so we are here to just fulfill that partnership pledge that we agreed upon. And we are happy to see that, that the work is ongoing. And so we continue to partner, we continue to walk the journey. It is continuous. We began last year, and we know we are moving further. So the vision is to have good mental health services in Nakuru across board. And CHP's kazi inaendelea vizuri? Mnaona kama inahitajika ama haitajiki? Kweli? Are these our community members? Are they our relatives? Are they our neighbors? So we are happy that we can help, and we cannot thank you enough because we know the work that you do ni kujitolea Mungu mbele, si ndio? Yeah. So tutaendelea na safari na tunawashukuru sana kwa hiyo safari mnaendelea na sisi. Thank you.
Thank you very much, Madam. Our guest of honor, the DG for Nakuru, our CEC. I first have to start by declaring that I am from Nakuru. Na watu wasiseme nilileta hii program nyumbani. It is because of the great partnership that the CEC showed and interest and commitment in doing this. In fact, I was looking at this banner and I was just telling the head of the Division of Mental Health that it's very interesting that we have the county having its own mental health and psychosocial support program for the county, and that's what we look for. Because sustainability for us is key, and when the county takes ownership, then everything works. Johnson & Johnson, for all of you, is one of the largest healthcare company in the world, and we are focused on bringing innovations for many diseases globally, and one of them is mental health. But these innovations mean nothing if the community is not aware, the health workers are not aware, and the health system is not primed to be able to provide them. And so in J&J, we have what we call the Global Health Equity, which is an organization that focuses on connecting communities to care. And there's no better way to do that, DG, except through community health workers. Because community health workers are in the community and they're able to link those patients to care. Since this program started, I just wanted to give you data. It might be a little bit, I hope it's the most current, but the community health workers, after their training, they have screened more than 44,000 household members in mental health. And from there, they have referred people who have been living with mental health conditions and were not aware and have been referred to care. And it's a very proud thing for us to see that members, especially people who did not know they have a condition, have now been linked to care. On top of that, the training of the MH Gap is now making sure that when somebody is referred, they find somebody who at least understands the basic mental health can provide care. The other component, DG, that we are providing, and I'm proud that we've progressed, is the training of psychiatry nurses. So as the director will tell you, we have a big shortage in psychiatrists, and therefore as the ministry bridges that gap, we need to have psychiatry nurses trained who we want to deploy at every level 4 facility, so that even when the MH Gap trained nurses and clinical officers find a case that they need to refer, they refer to somebody who's been trained at a higher level. And I'm glad that Nakuru, I think, provided 10 nurses, I think, in the current class, and we hope to continue that so that we can fill all the sub-counties in Kenya with psychiatry nurses trained. And one further achievement is that initially it was only KMTC Mathare that was offering psychiatry nurse, but through this program, we've now increased, and Nakuru KMTC is now offering psychiatry nursing as well as Kisumu MTC. So as a child of the county, I'm very proud that the program is doing well here, and I want to really thank the CHPs for the work that they've done, but more importantly, the CHAs, because any of us, if you work without supervision, sometimes you do not work well. So we are hoping that with these tablets, the CHAs will be able to support the community health workers better, and that will lead to even better results. So with that, I really want to thank you and wish you all the best.